Good morning, everyone, and welcome to our Klavano lectureship. It's so great to be here with all of you today. But first, I would like to acknowledge that I am on the traditional land of the first people of Seattle, Duwamish people, past and present, and honor with gratitude the land itself and the Duwamish tribe. And as you can see from the link below, if you want to learn more about this, the www.Real Rent Duwam site is an excellent site so you can help out. I also would like to acknowledge that many of you who are on this call right now or on this Grand Round site are on different lands than I'm on. And I would encourage you to go through tribal nations to determine which land you are on, to make sure you give with gratitude and honor some respect to those on whose land you are at this time. And now it is with incredible honor I want to introduce our Klavano lectureship, which has been in place since 1999, and I've been in charge of it since 2004. And the Klavano lectureship was donated to us by the Goffs, who are an incredible family who donated an endowed lectureship in honor of their friend, Jamie Klavano. This lectureship, basically the whole tenet of this lectureship was to make sure we brought people to Seattle via any way we could to teach us about holistic and integrative care. And I could honestly say that it is probably one of the most important things I've done in the last 15 years is bring in people from all aspects of holistic and integrative care, including music therapists, art therapists, dog therapists, Native American healers, and of course, also our incredible speaker today, Dr. Claudia Morris. Dr. Morris is a professor of pediatrics and emergency medicine at Emory University School of Medicine and is the research director for the Division of Pediatric Emergency Medicine. She's also an attending physician in the Pediatric Emergency Department at Children's Healthcare of Atlanta. She received her medical degree at Eastern Virginia Medical School in 1993 and completed a residency in pediatrics at Children's Hospital Oakland, followed by a fellowship in pediatric emergency medicine at Children's Hospital Oakland. She remained on faculty there until relocating to Emory in Atlanta in 2012. Dr. Morris is an RO1 funded investigator who has led several single and multi-center trials. She has a special interest in nutritional research that targets inflammation and oxidative stress, and has studied the arginine nitric oxide pathway in both sickle cell disease and asthma, and holds 3 INDs for nutritional interventions for the treatment of sickle cell disease and thalassemia. She published the first therapeutic study for the treatment of pulmonary hypertension and sickle cell disease, evaluating arginine, a nutritional supplement, in 2003, and recently published a randomized placebo-controlled trial of arginine therapy in children with sickle cell disease hospitalized for pain. Dr. Morris found an arginine deficiency plays a role in asthma as well as sickle cell disease. She believes that low bioavailability of arginine is associated with lung disease and deaths in patients with sickle cell disease. The goal of her research efforts is to develop novel interventions that minimize inflammation, hemolysis, and morbidity in these disorders, including sickle cell disease. It is with incredible honor that I introduce Dr. Claudia Morris, who is both a colleague and a friend, who sits with me on the executive committee for the section on integrative medicine for the American Academy of Pediatrics. I know this is our first Grand Rounds for Black History Month, and it is with an incredible honor that I introduce an incredible researcher working on a disease, sickle cell disease, and in terms of treatment for these incredible kids and their families. So without further ado, Dr. Claudia Morris. Thank you.
Thank you, Cora, for that introduction. And it is really my privilege to actually be part of this lectureship. Getting started, again, thank you so much, Cora, for that introduction, and again, for inviting me to speak today. So I have no relevant disclosures, but I will be talking about off-label use of L-arginine under an FDA IND. I have several CME objectives. I'll be identifying the role of arginine dysregulation in health and disease. I'll be listing the complications of sickle cell disease related to arginine deficiency. And by the end, you should be able to describe evidence-based benefits of arginine therapy in sickle cell disease. Well, since this is a holistic lecture, I wanted to point out that there are many paths to translating the foundations of integrative medicine to sickle cell disease. One of the earliest studies actually looked at 63 caregivers of children with sickle cell disease and asked about their pain therapy. And over 70% of these families were using complementary therapies. Prayer, spiritual healing by others, massage, and relaxation were the tops. But it also turned out that caregivers of children who were using the greatest number of conventional pain medications were much more likely to be using complementary treatments. And there's a growing interest in the field. There's also growing data. So beet juice, botanicals, biofeedback, N-acetylcysteine, garlic, resveratrol, my favorite. It's in red wine and grapes, and the skin has been shown to have hemoglobin F inducing activity. bet a lot of you guys didn't know that. And also yeah, accumulating evidence in the literature for fish oil, acupuncture, antioxidants, vitamins, nutritional supplements, and IVIG. And at the end of the day, food is medicine, and I've spent a lot of my time looking for ways to improve the health of patients with sickle cell disease nutritionally. So some may look at me in 2020 and think, wow, it looks so easy, right? But I wanted to give you an idea of the 20-year path that it took to get here. So, you know, in the early 1990s, I was a fellow at Children's Hospital Oakland, and I got my first pilot grant funding from the UCSF CTSA, which is actually the CTSAs are an unbelievable resource for trainees and junior faculty to get some funding started. Based on that pilot data, I was able to be awarded a K-23 Young Investigators Award by NHLBI, and that actually provided the ability to do our first phase 2 trial. I had a little bit of a challenge making that K-23 to R01 transition, as many people do. It can take several years and a lot of patience. But in 2009, NHLBI actually put out a call for clinical trials planning grants. And we had all this great arginine data. So I threw my hat in and got a terrible score and was very disappointed, but probably more disappointed by some of the comments of the reviewers. And I think that the one that stuck with me even to this day was a comment that said, no good science happens in the emergency department. I mean, I was, you know, dagger to the heart as the emergency medicine physician. How do you respond to that sort of perspective? And the thing is in fairness, there had been trial after trial that had failed in sickle cell disease due to poor enrollment and inability to achieve the target goals. But if you're doing a study in the emergency department, you really do need to engage those who work in the emergency department. So with that Pink Pages summary review, I actually reached out to Nate Cooperman, who was in PCARN, which is the Pediatric Emergency Care Applied Research Network. I didn't know him, but I knew of him, and I was inspired by that piece of paper to actually share it with him and ask what it would take to get PCARN endorsement for this sort of project. And so, of course, he supported my application, and I got unanimous endorsement for PCARN and started working with them in 2011. And you can see that, you know, I've been working towards this since then. We submitted a new R34 clinical trials planning grant in 2013, which did not get funded, but we resubmitted in 2015 and were successful in getting funding. That was to put together the phase 3 trial, which we submitted as a large multi-center UG3 grant to NHLBI in 2018. So again, not funded. Fortunately, before I gave up, I was awarded a K-24 mid-career grant from the National Center of Complementary and Integrative Health. And we also were successful in officially becoming part of PCARN in 2019. And then here we are in 2020, where we actually have successfully been awarded funding for the phase 3 trial. So, but you can see that this is a fairly long path, and it wasn't always easy. There were a lot of rejections from manuscripts that are now considered seminal papers in the field to multiple grants. That it took persistence, and along the way, I met a lot of unbelievable clinical scientists who really care about improving the lives for children with sickle cell disease. So it really isn't about any individual grant or paper, but more about the journey. And I hope that can be, inspiring to any of our junior faculty or trainees who may be overwhelmed by this whole grant process. Others may wonder, why is an emergency medicine physician talking about arginine and nitric oxide? That seems a little bit out of my wheelhouse. And so this timeline, puts it in perspective. So in 1980, endothelial-derived relaxing factor was first described. In 1987, vascular endothelial cells were found to generate nitric oxide gas. And 1987 was a really important year for me because I just graduated from Boston College. Doug Flutie won the Heisman Trophy, and I landed my first job before I planned to go to medical school in a lab at Cornell University under the oversight of Carl Nathan, who's one of the early pioneers in the nitric oxide field. And he believed the endothelial-derived relaxing factor was nitric oxide gas, while the rest of the world thought that was fake news. So it was a really interesting experience to be in this controversial lab, but it was also my first experience with a strong and supportive mentor. And I had no idea at that time how my experience in that lab would translate to the rest of my career. But at the time, I was able to take all the biology I learned in that year and translate it to sickle cell disease 10 years later. So in 1988, nitric oxide was found to be synthesized directly from L-arginine. And then in 1998, the Nobel Prize was awarded for the nitric oxide discoveries. And then this is the time I was a fellow, was starting to dabble in arginine and nitric oxide in sickle cell disease. So when does a physiologic state result in a unique nutritional requirement? Well, the essential amino acids are diet dependent, whereas non-essential amino acids are made by the body through de novo synthesis. Yet there are conditionally essential amino acids, which are non-essential amino acids that ultimately become indispensable under stress and critical illness, where the capacity of endogenous synthesis is surpassed. And arginine happens to be one of these amino acids. There's a number of conditions that are linked to an acquired arginine deficiency, so you weren't born with it, many which do fit in my wheelhouse as an emergency medicine physician: trauma, critical illness, burns, and sepsis. My focus is on sickle cell disease, and the mechanism is hemolysis. This has implications to thalassemia, malaria, even blood storage lesions. So what is arginine? It's this conditionally essential amino acid found in the diet that's synthesized through the intestinal renal axis, but it becomes essential under conditions of stress and hemolysis where the body just can't keep up with production. It's found naturally in the diet. A lot of people ask me what kind of foods are high in arginine. So things that are high in protein: meat, dairy, seafood, nuts. And interestingly enough, a watermelon has got a lot of arginine together with citrulline. And a normal adult ingests somewhere between 2 and 7 grams a day, which is important to know because you realize that you really can't get enough arginine just from your diet to impact nitric oxide production. If you look at the doses that we're giving later on in the studies I'll mention, it's a nutritional supplement with low toxicity that has been studied for decades. And ultimately, it's the obligate substrate for nitric oxide production. It's also being marketed on the internet as the natural alternative to Viagra. So now all of you guys in Zoom land are never going to be able to look at watermelon in the same way again. So this slide shows you the sources and metabolic fate of arginine. Don't worry, I'm not going to go through all of this, except it shows you that it's complicated, right? It's more than just arginine as a nitric oxide donor, right? You've got all these other pathways that come into play. I'm going to be talking about arginase, but for those out there looking for a career where there's a niche that has a gap, creatine is really important in mitochondrial function and in the detoxification pathway. And there's been no studies of this in sickle cell disease, and we have no idea what agmatine does, but these are all probably equally as important as the nitric oxide synthase and arginase byproducts. So in the presence of nitric oxide synthase, arginine is converted to nitric oxide. As I mentioned, it's one of the most potent vasodilators, which is why it would play an important role in a condition like sickle cell disease where you're dealing with vasoconstriction. It also can inhibit platelet aggregation, has some anti-inflammatory and immune response, works as a signaling molecule, and can inactivate superoxide. So what about arginase? This is an important enzyme in the urea cycle, and I may be bringing you back to medical school talking about the urea cycle, but it is found, at least we know of 2 mammalian isoforms: arginase 1, that's cytosolic, and then arginase 2, that's mitochondrial. And what's interesting about arginase is that it's present in most cell types, including the red blood cell, which makes it a really intriguing enzyme to study in hemolytic disorders, where it's going to be dumped into circulation upon hemolysis in an active form. It's also induced by a number of cytokines, so it plays a role in several inflammatory pathways and ultimately competes with nitric oxide for their common substrate of arginine. So in the presence of arginase, arginine gets converted to ornithine and urea. Ornithine and arginine use the same amino acid transporter to get into the cells, CAT1 and CAT2. So as you have an increase in ornithine in the presence of arginase, you end up having competitive inhibition of intracellular transport of arginine, which is going to limit your arginine bioavailability and ultimately translate to decreased nitric oxide bioavailability. And this may actually have an even more important part in compartments. So this cartoon just gives you an image of what I was just talking about. So arginine gets converted to nitric oxide by nitric oxide synthase, yet we know that nitric oxide synthase is paradoxically is increased in a lot of inflammatory diseases, including sickle cell disease, yet you have this paradoxical decrease in nitric oxide. And we'll talk a little bit more about why that the mechanisms that cause this issue. But we do know from work from Lewis Su and colleagues that looking at the sickle cell mouse model, that although nitric oxide synthase is upregulated, it's actually uncoupled, which means that it's dysfunctional in producing superoxide instead of nitric oxide. In addition, you have the substrate competition from arginase, where arginine is converted to ornithine, and then the downstream byproducts of arginase activity, the polyamines and prolines, which lead to vascular smooth muscle proliferation, airway remodeling, collagen production and deposition, lung fibrosis, the sort of structural changes you see in the lungs of sickle cell disease with common pulmonary comorbidities such as asthma and pulmonary hypertension. But again, you see these proliferative changes also in other organ systems like the kidney. There are a number of sources of arginase. So as I mentioned, in hemolysis, it's mainly coming from the red blood cell. But in trauma, it's coming from these neutrophils called myeloid-derived suppressor cells. And inflammation, cytokines can increase your arginase. If you've got acute liver injury, your arginase is going to go up as your liver function, as your liver enzymes increase, and there are genetic polymorphisms that can also increase your arginase activity. So when we talk about arginine bioavailability, you can see from this that it's so much more than just the plasma concentration of arginine. And I didn't understand this back as a fellow, but that we had all these other mechanisms that were impacting arginine bioavailability. But now when we talk about arginine bioavailability, we talk about the Arg to ORN, or the Arg to ORN plus citrulline ratio, because it takes into account the impact of arginase and that of kidney dysfunction. So as I mentioned, arginine should never be rate limiting in health and disease because it is non-essential, but really conditionally essential, meaning that it is made through, the body has the ability to synthesize it through the intestinal renal axis. So your diet, you take up glutamine, and it gets converted to citrulline in the small intestine. Now you may recognize glutamine as an amino acid that was recently FDA approved for the treatment of sickle cell disease, and now it's got a fancy name and DARI and a fancy price tag, but it is just a nutritional supplement. And it is also an arginine prodrug. So when we think about mechanisms of glutamine, I have some data that I won't be showing that actually shows that oral glutamine increases arginine bioavailability. So gets converted to citrulline in your small intestine, and then citrulline gets converted to arginine in the kidney. So you can imagine that patients with kidney dysfunction are going to be at a disadvantage. They will not be able to convert citrulline to arginine. And from our large cohort of adult patients with sickle cell disease, we saw a strong correlation between rising citrulline levels and rising creatinine levels, suggesting again a block in this conversion. So there's a number of mechanisms of arginine dysregulation. We're going to talk a little bit more about hemolysis, which increases arginase activity, but there are a number of other pathways that increase arginase activity. As I mentioned, inflammation, these myeloid-derived suppressor cells that play an important role in trauma, and there's some data now to suggest it also plays a role in COVID. Intracellular transport abnormalities, renal dysfunction, and then you can have endogenous nitric oxide synthase inhibitors like arginine analogs, like asymmetric dimethyl arginine, which is a robust biomarker of cardiovascular disease. And then NOS can also be dysfunctional and uncoupled, as we see it is in the sickle cell mouse model. So, a drop in any specific amino acid does not necessarily translate to a clinically significant deficiency. In order for nutritional deficiency to be present, you have to have the biological process that's dependent on the nutrient to be compromised. That compromise leads to an abnormal physiologic response that's causative of poor outcomes. And those poor outcomes need to be reversed by amino acid replacement. So, and I want you to keep these three concepts in mind as we start talking about the arginine story and the data that we've accumulated over the last 20 years. Because ultimately, sickle cell disease is a model for distinctive nutritional requirements that arise from a chronic disease that has implications for a lot of other diseases. So it's a model for vasculopathy and endothelial dysfunction. We talked about hemolysis and inflammation, but also involved in this is arginine and nitric oxide depletion. So another cartoon, the mechanisms of arginine, the mechanisms of vasculopathy and endothelial dysfunction in sickle cell disease seem the depletion of nitric oxide takes central stage in this. And the mechanism is really through hemolysis, right? So normally you have safely encapsulated within the red blood cell all the contents of the red blood cell that gets dumped into circulation during hemolysis. So you've got release of the cell-free hemoglobin, which rapidly consumes nitric oxide. Then you also have a high concentration of arginase 1 in the red blood cell that consumes the obligate substrate for nitric oxide production. So you have a drop in your arginine level. And as your arginine levels are depleted, you end up reaching a threshold level below which nitric oxide synthase uncouples and becomes dysfunctional and is producing superoxide in lieu of nitric oxide, which further consumes nitric oxide and creates reactive nitrogen oxide species, which leads to cell damage and cell death. So, this is all adding to this milieu of oxidative stress. And when you look at this, you can see that it appears to be a global disruption of the arginine nitric oxide pathway with so many areas that you could potentially target. So when we think about therapies, we do need to change our thinking about hoping we're going to find that silver bullet, that one intervention that's going to cure this very complicated disease. And most likely we're going to need multimodal therapies that hit different mechanisms. There are consequences of decreased nitric oxide bioavailability that translates to increased endothelial activation, increased endothelin 1, which is a potent vasoconstrictor, increased platelet activation that has clinical manifestations that include pulmonary hypertension, stroke, priapism, leg ulcers, renal insufficiency. These have become known as the clinical, the hemolytic phenotype of sickle cell disease. And I've spent a lot of my time and attention focusing on the pulmonary complications because first, these are treatable phenomenon, and any condition that's going to compromise your oxygenation is going to lead to this vicious cycle of sickling. So now we've known as early as 2003 from Ryder and colleagues that nitric oxide is inactivated in sickle cell disease, and this inactivation correlates to hemolytic rates. So as you have an increase in plasma heme, you have an increase in your nitric oxide consumption. But what we've added to the story is that it's not just a nitric oxide depletion, but arginine is decreased arginine bioavailability is also part of this story due to increased destruction and consumption and decreased production. And it turns out the enzyme arginase plays a really important role in this model. So now this is data that I put together from my early collaboration with Mark Gladwin and Greg Cotto when they were at the NIH, and they had this really robust, large prospective cohort of sickle cell adults that they were following. And we found that arginine levels in these patients with sickle cell disease were very low compared to controls. But what was interesting is the first time we actually looked at plasma arginase levels, and they were very high in our patients with sickle cell disease compared to normal control levels that are barely measurable. So if you remember me mentioning that arginase is an intracellular enzyme that's released upon cell damage or cell death, if you are healthy, you just should not have arginase floating around in your plasma. And what was interesting is that the patients who had the highest levels were patients who ultimately died early. So again, some early red flags that this may play a role in survival. So because of the effect of arginase on arginine to ornithine, we looked at this ratio of arginine to orn as a surrogate of arginase activity and found that this ratio was low in our patients with sickle cell disease compared to normal controls. But what was interesting is this clinical observation that the lowest levels were found in patients who are at highest risk for pulmonary hypertension. So again, the patients with the lowest arginine bioavailability or highest arginase seemed to have clinical symptoms of pulmonary hypertension and were dying early. So one of my earliest studies in the concept of, well, if this is, an arginine deficiency, if it's low, let's give it back. We had some pretty compelling data on our patients with pulmonary hypertension. So we did this small pilot oral arginine study where we gave patients with pulmonary hypertension 5 days of oral arginine, and their pulmonary hypertension was defined by a Doppler echocardiogram. They did not have a right heart cardiac cath, which is the appropriate way to diagnose pulmonary hypertension. But these patients were identified before we were screening patients for pulmonary hypertension, and their TR jets, I think the mean TR jet was like 3.2. So these patients clinically had pulmonary hypertension. And what was impressive is that we saw a decrease by over 15% in their estimated pulmonary artery pressures within 5 days of therapy. And this is consistent with the type of effects you would see with a pulmonary hypertension drug like sildenafil. So again, this one patient who had no change was interestingly admitted to be non-compliant because he didn't like to take the pills. And when you take arginine, your plasma arginine level will double or triple. So you can tell when someone's actually compliant, and his arginine level is even lower at the end of the study. So again, we were pretty excited about this, and this actually turned out to be the first publication for an intervention for pulmonary hypertension and sickle cell disease. So looking at the arg to orn ratio, I actually teamed up with Sid Morris, who was an arginine arginase expert and of no relation. And we showed that this biomarker, this arg to orn ratio, was a really nice reflection of arginase activity. And now there's a lot of investigators who use the arg to orn ratio as a surrogate for arginase activity. What we also found out, though, was that low arginine bioavailability is also associated with increased risk of death, as reflected by the arg to orn ratio, but also the arg to orn plus citrulline ratio. So here we had, now this is again work that I did in collaboration with Mark Gladwin and Greg Cotto when they were at NIH. We obtained a single blood test over here, and then we followed these patients over 50 months. And this is the group. There was no deaths in the patients who had the highest arginine bioavailability, and the most number of deaths in the patients who had the lowest arginine bioavailability, with a risk ratio of 3.6. So again, this was striking. One of our collaborators who worked on this study and ran the amino acids for me was Stan Hazen at Cleveland Clinic. So he actually took this information and applied it to a large cohort of patients that he had, almost 1,000 patients at risk for cardiovascular disease who were undergoing right heart cardiac cath. And he looked at the incidence of MACE, which was major adverse cardiovascular events defined by death, repeat heart attack, or stroke. And here you've got the years. He followed them over 3 years, and you've got MACE on the y-axis. The yellow line are the patients who had the lowest arginine bioavailability, and the blue line is the patients who had the highest arginine bioavailability. And you can see, again, like our patients with sickle cell disease, those with low arginine bioavailability were at increased risk of death and other major bad outcomes of cardiovascular disease. In fact, he found that this single blood test was more predictive of bad outcomes for cardiovascular disease than cholesterol. So again, it seems that arginine bioavailability is important to survival, and that has implications beyond sickle cell disease. So now we're going to change it up to pain and bring it into my wheelhouse as an emergency medicine physician. As many of you know, pain is the hallmark of sickle cell disease. It's the leading cause of hospitalizations and the reasons that I see patients in the emergency department. It's also associated with increased mortality. Yet there's no effective treatment targeting underlying mechanisms of acute pain, and symptomatic relief with opioids has been the mainstay of therapy for a long time. Many people also use fluids with that has no evidence to support it. And in fact, there may be some risk of harm giving boluses. So ultimately, therapies targeting mechanisms of vasocclusion are needed. So now I'm going to go back to my early work. And again, this actually can demonstrate to all the junior faculty and trainees that work that you do as a fellow can really have implications on your career. So again, with my UCSF CTSA award, we collected pilot data looking at arginine nitric oxide levels in patients when they came into the emergency department. When I first started looking at this, what was in the literature already was a few publications that talked about low arginine levels at baseline in patients with and adults with sickle cell disease, but no explanation of the mechanism, and there was no data on kids. So what we found was that arginine nitric oxide levels dropped significantly during acute episodes such as pain crises and acute chest syndrome. But what's interesting is that the lowest arginine levels were found in the patients whose pain was severe enough to require admission. It was actually a very sensitive and objective measure to identify patients who required admission. And what's interesting is that nitric oxide metabolites, although the patterns mirrored the arginine levels, were not predictive of admission. So here we have our pediatric controls. At baseline, kids are not that, they're a little bit lower, but not that far from their normal controls. However, when they come into the emergency department in pain, their arginine levels are significantly depleted, and even more so when they're admitted. So here you have the follow-up of their course throughout their hospital stay. And at the time of admission, you can see by the time they're convalescing and their pain's improving at discharge, their arginine levels are returning to their previous baseline level without us doing anything else. So again, with this concept of if it's low, give it back, my intention was always to demonstrate that there was a deficiency and then actually work towards a supplement or an arginine supplementation trial. But we started out with controls because we knew from the literature that if you gave arginine to a healthy control, you were able to increase their nitric oxide metabolites. So again, at the time, I was thinking this is absolutely involving nitric oxide. So I wanted to look at the impact of nitric oxide production. So here are our controls. This is the time in minutes. It's a pharmacokinetic study, and this is the change in nitric oxide metabolites. And you can see that there was significant increase in nitric oxide metabolites with the peak at about 90 minutes after taking an oral arginine dose. So then we moved on to our patients with sickle cell disease, and we found this paradoxical decrease in nitric oxide metabolites that really got me scratching my head, and some people telling me to let the project go because this was not a good observation, right? It seemed like we were making things worse. So not really understanding why that would be, we thought maybe it had something to do with dose. So we actually so our initial dose was 100 milligrams per kilo, which is similar to the dose that they use in cardiovascular literature shown to be needed to increase nitric oxide production. We gave a much higher dose at 250 milligrams per kilo, and we saw the dotted line, the same paradoxical decrease. So, one last time before I gave up on the idea, I thought, well, our data showed that their levels were low during acute pain, although they seemed close to normal in kids, at baseline. So we changed our protocol, made an amendment to the IRB, and gave oral arginine during a pain crisis. And again, we saw this dramatic increase in nitric oxide metabolites. So what this told me is that not only were patients with sickle cell disease metabolically different with respect to arginine bioavailability compared to normal controls, but they're metabolically different during an acute pain crisis as well. And I think that's important. So every patient we brought in pain, we saw the significant increase in nitric oxide metabolite, although there was a variable of what their response was. So then we brought them back and gave them half the dose, and again saw this paradoxical decrease. I stopped after 3 patients because we felt like we had settled on our dose, which would be 100 milligrams per kilo, but this does appear to be dose dependent. And again, at this time, I didn't know anything about arginase and arginine analogs, but there does appear to be a specific concentration that you need to get above in order to see an effect on nitric oxide production. So this data was the pilot data that led to my K23 award by NHLBI. And we performed a blinded randomized placebo-controlled trial of L-arginine, where we gave 100 milligrams per kilo IV or PO 3 times a day. This started out as an oral arginine trial, but we had a heck of a time the first year getting kids to take the pills. And so enrollment was very, very slow. We ended up changing it to an IV delivery, and then we were able to pick up our enrollment. But kids, when they were sick, just didn't feel like taking, the pills or anything mixed in juice or soda. We enrolled 56 children over the age of 3 years who were admitted for pain, and we found a significant opioid sparing effect of arginine. So 55% reduction in opioid use in the arginine arm compared to placebo. So a total of 1.8 milligrams per kilo of morphine equivalents compared to 4.1 in the placebo arm. And this remains statistically significant even when we eliminated these two outliers. We also saw a decrease in pain scores in the patients who got arginine compared to placebo, very similar at admission, but a decrease in pain scores by over 2 in the patients who actually received arginine. We were not powered to see a decrease in the length of hospital stay, but we did see a clinically relevant decrease of 17 hours. So, and if we look at it, so in order to be powered for length of stay, you need a trial that's going to evaluate over 300 patients, and that was definitely out of the budget for my K23. But when we looked at the correlation between total opioid use and length of hospital stay, there's a really nice and not unexpected correlation. So this is a nice surrogate for length of hospital stay. Makes sense. The longer you're in the hospital, the more opioids you're going to be using. So then getting back to this idea of mechanism of action, although, it is likely that as the obligate substrate for nitric oxide production, nitric oxide plays a role. We know that nitric oxide also increases production to stimulate mitochondrial biogenesis, scavenges mitochondrial antioxidants, plays a role in the TCA cycle, and actually the arginine metabolism to creatine could be important in mitochondrial homeogenesis. And work by Shruti Shiva and her colleagues published in Blood showed that there was a mitochondrial dysfunction in patients with sickle cell disease. So what Shruti and I kind of teamed up on this effort, but what she had found was that patients with sickle cell disease had lower complex 5 compared to normal controls. No one had ever looked at sickle cell patients with pain before. So here's the complex 5 in sickle cell patients at baseline, which is lower than normal controls. And we found even lower still in patients with acute pain as they presented in the emergency department. We found no difference in patients with acute pain compared to steady state in complex 4. So what we did is we looked at 3 different doses of arginine, and this was part of the R34 clinical trials planning grant, trying to figure out what's the best dose for our phase 3 trial. We used one dose, which was IV arginine, 100 milligrams per kilo, given 3 times a day. Then we gave a loading dose, which was 200 per kilo, followed by the standard dose. And then the third arm was a loading dose followed by continuous infusion. And this was based on some of the malaria literature that showed that there was a difference in pharmacokinetics in patients with mild malaria versus severe malaria, where the same dose of arginine was not reaching the same concentration in patients who were more severe, which makes sense. You've got increased hemolysis, increased consumption by arginase that could impact this. So we looked at complex 5 and complex 4, and we found significant increase. Oh, and this is so VOE baseline is actually when they showed up in the emergency department. So this is their ED presentation for pain, and these patients were all admitted to the hospital, and this is their levels at the time of discharge. And we saw increase in complex 4 and complex 5 across all of the arms of arginine therapy, but the greatest effect was found in patients with the loading dose. We also looked at citrate synthase activity, again, increased across all arms, greatest in the loading dose. Some may say, well, you know what, you're looking at these were platelet mitochondria, so it could just be a matter that you've got more mitochondria at the end of the study when patients have recovered. So this study actually looked at the mitochondrial DNA and showed that there's no difference. There's no difference in the mitochondrial DNA across the study. So really suggesting that we were having an impact on mitochondrial function. Protein carbonyl, biomarker of oxidative stress, again, decreased by the hospital stay with the greatest effect in patients who had a loading dose. So this was the first report of increased arginine therapy. This is the first report that arginine therapy increases mitochondrial activity in patients with sickle cell disease and has implications for improved metabolism and oxidative signaling. And ultimately, this could be a good biological outcome measure for exploratory for clinical trials that where we're looking at mechanism. It's fairly easy to measure. You freeze the platelets and you can analyze them later in batch. Okay, there we go. So next, I want to talk to you about a really exciting second phase 2 study that just recently has published out of Sub-Saharan Africa. And this was done by Dr. Richard Onolo, from the University of Abuja, Nigeria, who has become my star K24 mentee. So he approached me a few years ago. He had been following my work and was really interested in doing an arginine study in Nigeria. And I thought, knowing it took me 9 years to do my arginine study at Oakland, that I was very skeptical that he was actually going to be able to successfully do this, but he had all the right stuff. He had the right enthusiasm. He had some really great ideas. So I decided to work with him on his protocol. And his objective was to determine the role of oral arginine in the management of children with sickle cell disease admitted for vaso-occlusive pain in Nigeria. He performed a blinded placebo-controlled phase 2 trial at 2 hospitals in Nigeria, where patients received 100 milligrams per kilo of arginine solution that was mixed in grape juice and taken orally, observed by the nurse or research staff to be taking the therapy. I was given every 8 hours for 5 days. And a lot of this was based on our early protocol from the Oakland study. So he obtained blood samples before and prior to admission and then at discharge. And what he used as his primary outcome measure was something called the medication quantification scale, the MQS tool, to assess analgesia use. So again, things are different in Nigeria. They do not use IV opioids in the same way that we do in the United States. Patients will come into the emergency department and maybe they'll get a single dose of IV opioids, but they're very quickly transitioned to orals. So using parenteral opioid use as a primary outcome measure just wouldn't work in Nigeria. So fortunately, this MQS score was validated in patients with sickle cell disease by Jacob and colleagues, and gives you a good idea of all analgesia use. And opioids were converted to morphine equivalents. Inclusion criteria were age 5 to 17 years with sickle cell disease, admitted to a pediatric unit for pain, who had a numerical pain score of 7 or higher on a scale of 0 to 10. His outcome measures, he looked at change in analgesia medication as based on the MQS scores as primary outcome, differences in pain score, time to crisis resolution, and total length of hospital stay. So here's his baseline character. 68 patients were recruited, 35 into the arginine arm and 33 into the placebo arm. They were about 10 and a half years old. Gender was fairly equally distributed. Only about 13 to 14% were on hydroxyurea, which reflects the lower use of hydroxyurea in Nigeria, and high pain scores at presentation. So what he found was that oral arginine increases plasma arginine and global arginine bioavailability. So you know from our earlier work that if you do nothing, your arginine level returns to normal, right? So what he found in the arginine arm is an increase in arginine concentration by 125% versus an increase in 29% in the placebo arm. And global arginine bioavailability increased significantly by nearly 60% in the arginine arm compared to no change in the placebo arm. He also found that an impact of oral arginine on analgesia use, with the MQS score was significantly lower in the arginine arm compared to placebo, 73 versus 120. So again, this is his primary outcome measure, and it was very significant. Looking at the impact on pain scores, the mean daily rate of decline in pain scores was faster in the arginine arm compared to placebo. So here on the x-axis, you have the 5 days. Here you've got this is the least pain score. Red is the placebo group and blue is the arginine group. And on the right, the figure is worst pain scores. So, and again, you can see that even by day 2, you're seeing a divergence of the pain scores in the favor of the arginine arm. And then I think this was the data I was most excited about, is the impact of oral arginine on time to crisis resolution and length of hospital stay, particularly since time to crisis resolution is the outcome measure that the FDA favors for regulatory purposes. So he found a significant decrease in time to crisis resolution by day 5, 54% of the children on the arginine arm were discharged compared to only 24% in the placebo arm. Now, unfortunately, when you define crisis resolution by a pain score less than 4, anyone who works with patients with sickle cell disease recognizes that there's quite a few patients who never achieve a pain score, less than 6 or 7. So a lot of patients were censored here, but of course we had length of hospital stay on all patients, and there was a significant decrease in length of hospital stay in the arginine arm with a decrease mean of 46 hours, almost 2 days decreased stay in the hospital, which is actually incredibly relevant for patients in Nigeria, which is a low resource area. As far as adverse events, there were 4 serious adverse events in the placebo arm, the empyema, osteomyelitis, and there was 1 death. This was actually due in review of the chart to oversedation, unfortunately. And a reminder that oversedation is always an issue and these kids need to be monitored closely. There were no SAEs in the arginine arm. There were plenty of AEs. They were all mild, similar in both groups. But there was a trend towards increased vomiting in the arginine arm compared to placebo, although this did not reach statistical significance. It was 19.4% versus 3.1%. So I do think this is clinically relevant and not unexpected because taking oral arginine can cause upset. And I think the take-home message for this is that we probably should be giving an antiemetic like Zofran when using oral arginine. So in conclusion, arginine deficiency plays a role in sickle cell disease and pain, that oral arginine plus conventional analgesics are superior in pain control than use of analgesia alone, that oral arginine therapy increases the rate of pain reduction, enhances early achievement in analgesia, reduces opioid NSAID requirement, is generally safe, and ultimately shorter time to crisis resolution and reduces length of hospital stay. And this just came out in print, I think, last week in American Journal of Hematology, and Dr. Analo was awarded his PhD in December. One of the interesting take-home messages I got from differences in locations where you're doing pain, where you're doing studies, is that, you know, when he proposed this oral arginine study to me, I thought, oh gosh, we couldn't get these kids to take oral arginine. And what happened in Nigeria is that they are the children in the hospital do not have access to juice. So everybody wanted the juice, and in fact, the kids were asking for juice even outside their scheduled 3 times a day, medication supplementation. So key points here: arginine is a conditionally essential amino acid that becomes essential under conditions of stress and catabolic state, where the capacity of endogenous amino acids is exceeded. This includes hemolysis, critical illness, trauma. And stay tuned, we have a paper under review that suggests that this may play a role in COVID and MIS-C as well. Sickle cell disease represents an arginine deficiency syndrome. So you have a distinct nutritional requirement that may ultimately benefit from arginine replacement therapy. When again, you think about these points that I brought up early on, for nutritional deficiency to be present, the biological process must dependent on the nutrient is compromised, which we see in pulmonary hypertension and sickle cell pain. That compromise must lead to an abnormal physiologic response causative of poor outcomes, and those poor outcomes should be reversed by amino acid replacement. So it's a debate whether or not arginine is working as a drug, or if we are truly treating a nutritional supplement. And I suspect that patients with the greatest arginine deficiency are going to be the ones who will benefit most from arginine therapy. So the mechanism of arginine is likely multifactorial, and the next step would be, of course, the definitive phase 3 trial. Fortunately, NHLBI agreed with us, and they just funded an $8.7 million grant for us to do this study. I want to introduce you to the START trial, sickle cell disease treatment with arginine therapy. Our goal is 360 patients. That seems lofty, but I know we can achieve it. Our hypothesis is that arginine therapy will decrease time to crisis resolution and total opioid use in milligrams per kilo, and ultimately improve pain scores and patient-reported outcomes in children with sickle cell disease and pain compared to placebo. We're proposing to do the pivotal and definitive phase 3 multi-center randomized placebo-controlled trial of IV arginine in children with sickle cell disease and pain. And ultimately, I hope that before I retire, I will be able to give you the answer as to whether or not this is a therapy. Our specific aims hit efficacy, safety, and exploratory. We've talked about the time to crisis resolution. This is the outcome measure favored by the FDA, and I've been working closely with the FDA for the last 20 years, and we plan to apply for orphan designation this year. We're also looking at ongoing safety, and then we have these exploratory aims trying to understand the mechanism, looking at arginine, the impact on arginine metabolome, and in particular, the effect on mitochondrial dysfunction. One of the reasons I'm excited about this impact on mitochondrial dysfunction is that we can borrow from the mitochondrial literature, right? I mean, a mitochondrial cocktail is a nutritional combination of like 10 ingredients. And if we can show that there's mitochondrial dysfunction, then we don't need to go and treat every single study every single ingredient in isolation, because we really need to look at them in combination to get the best effect for our patients. We're also proposing to develop the largest sickle cell disease with pain biorepository. One doesn't really exist right now. It's hard to get these samples in kids when they're in acute pain. And now we've got, the efforts of 10 sites and 360 kids. So that's part of the project. I get a lot of questions about safety. Arginine is actually incredibly safe. It was FDA approved in 1972 for growth hormone stimulation tests, and they use much higher doses than we do, 500 milligrams per kilo. It's actually being used off-label now at 600 milligrams per kilo IV, 3 times a day or every 8 hours for acute hyperammonemia. So a lot of folks are worried about liver injury. However, it looks like arginine actually may be beneficial for your liver. Hyperkalemia is a true risk in patients with acute renal or hepatic insufficiency. In particular, there was one death of a child who got a significant overdose. But otherwise, it is quite safe. Oral arginine side effects can be nausea, vomiting, headache. IV side effects are similar, but often attributed to a rapid infusion. Pfizer, that actually makes the IV infusion for growth hormone stimulation test, reports about 3% of patients with nausea, vomiting, flushing, or headache. Allergic reactions to arginine are rare. It can be infused over 30 minutes. And if patients are having some of these symptoms, if you slow down the infusion, a lot of times it resolves. And at this point, we have growing experience with arginine therapy in sickle cell disease. I've now enrolled over 180 patients in IV arginine studies versus placebo. We've had no unexpected AEs or SAEs related to the study drug to date. So how are we going to pull this off? 360 patients. Well, we have the start sites have been identified from our R34 as high volume sites. These are our sites here. Together, we see over 3,800 pediatric ED visits for pain. So that really is amazing, considering this is an orphan disease. And there's an annual admission of over 2,400. So in order to randomize 360, we need to screen 5,000 patients a year, which again sounds like a lot. 5,000 patients total, 1,000 patients a year, but that translates to 100 patients screened per site. So 10 sites enrolling, 36 total each over 5 years. So that's just 7 to 8 per year per site, or 6 to 7 patients per month, which is absolutely feasible with PCARN. So for those of you who aren't familiar with PCARN, it's the Pediatric Emergency Care Applied Research Network. They were funded in 2001 by HRSA's Emergency Medical System for Children's program, first federally funded PEDS emergency medicine research network. They award these cooperative agreements to academic medical centers through a competitive and painful process every 4 years, and basically present evidence-based research in emergency care for kids that's changed our practice. And our center at Children's and Emory are the newest members of PCARN as of September 2019. And I'm in excellent company because you guys at Seattle are also new members of PCARN. So our node is the San Francisco, Oakland, Providence, Atlanta Research Collaborative, or SPARC. And our leadership is we're coupled with Brown, UCSF Oakland, my old home, and we have funding through 2023. But we hope to be with PCARN for a long time. So I just wanted to show this because, as I mentioned earlier, there was skepticism that we could successfully complete these these randomized controlled trials in patients with sickle cell disease because there had been so many failed treatments, failed studies, with challenges of meeting their enrollment goals. So this was written in blood about the PCARN Magic trial, which was led by David Brousseau through PCARN. And I love this because it's magic. The pain remains, but kids with sickle cell disease appear. And this is because when you actually have a good collaboration between the hematologists and the emergency medicine physicians with experts and champions who know how to do clinical research, you're going to have success. And what David Brousseau did with PCARN is they enrolled 208 patients in less than 3 years, which had never been done before, and which is why it was so important for me to go back to NHLBI with the PCARN endorsement. So, and finally, I'd just like to acknowledge my funding sources, particularly NHLBI, National Center for Complementary and Integrative Health, and the FDA, my collaborators at Emory, my early collaborators from University of Pittsburgh, my my key star mentor, Richard Analo, for his excellent project in Nigeria. And then, of course, I want to give a shout out to my early mentors and collaborators, Elliot Vachinsky and Franz Kuipers, who were my mentors for my K-23, who have gone on to become long-term collaborators and friends, again, demonstrating the importance of strong mentorship across your career. And then finally, I'll just end with this question. What do you do if you're stuck in Atlanta and it's hot and you've got a pandemic and you want to get out to the West Coast? Well, my family rented this RV and they jumped in and spent the summer driving across the country and visiting state parks. But you know, when I stepped back and I looked at this small RV, the dog, the cat, and everything else, did I say it was about the journey? I opted to buy a flight straight to Lake Tahoe and put on my N95 and met them there while they cruised across the country. So anyway, thank you so much for your attention. I'm open to questions.
Wow. Thank you so much, Claudia. That was amazing. And what I love about it is, yeah, I went back to medical school. And you explained it really well, actually. I remember a lot of that stuff, not all of it. And what I loved about what you presented, especially I love the fact that it's part of this Grand Rounds, is it does show that holistic and integrative medicine is about the journey, and it's about showing all aspects of treatment of the child and their family and caregivers. And so it is a total treatment intervention with an outcome that is positive. So I have one question. There's a couple questions coming in the chat, but I just, it's probably a stupid question, but why L-arginine and not L-glutamine as the intervention? Why did you go 2 steps from glutamine in terms of your treatment?
So that's actually an excellent question, and especially now that glutamine is FDA approved, right? I think that there's a few issues. One, we had a challenge with oral supplementation, right? And we ended up going to IV, you know, and that was a different experience than what they had in Nigeria. But IV glutamine is not stable, and a lot of the questionable concerns of glutamine in the literature in critical care are related to IV glutamine. So oral glutamine is actually incredibly safe and will get converted to arginine as long as you have normal functioning kidneys. At the time that I started working with arginine, I actually wasn't aware that glutamine was an arginine prodrug. That led to my first R01 actually, when a biochemist pointed out that, you know, these glutamine levels predicted, you know, low glutamine in your red blood cell predicts risk of pulmonary hypertension. We published that a few years ago, but it took a biochemist to say, Claudia, you recognize that that's an arginine prodrug. And I was like, you're kidding. So thus my first R01 was successful. But we chose arginine 1 because that was what I knew from a biochemical perspective from the lab that I'd worked in. It made sense that there was an arginine deficiency that I was trying to you know, reverse. Having said that, I think that there's promise for glutamine. I'm a big fan of glutamine. I mean, it's not the cure for sickle cell disease, but it certainly decreases the number of acute chest syndrome, decreases pain episodes, and I believe that part of its mechanism is working through increasing arginine bioavailability. But that's taken orally as as a prophylactic.
Thank you very much. And I see one of my mentors, Dr. Kathy Kemper. Hi, Kathy, is on this, who says, thanks for an outstanding presentation and made it all much more clear. So thank you very much for Dr. Kemper's being on this. Dr. Bender's on too. Back to glutamine. Any thoughts on the bad outcomes when used in an ICU setting?
Thanks for bringing that up. I think that this adds to a lot of this amino acid fear. It was IV glutamine, and that's the thing is IV and oral glutamine are very different. So arginine is stable in the IV form. It's an important part of any parenteral nutritional formula that's used. IV glutamine is not stable and it gets converted to a lot of metabolites that actually could have adverse outcomes. So although I think oral glutamine is safe and actually it makes a lot of sense, and if you look at the critical care, the studies, those that used enteral glutamine and NG feeds actually were positive. There are a handful of studies where they mixed oral with IV, and it's that difference that is not pointed out in the study that really is a critical difference.
A lot of thank yous coming through, and we only have about a minute left. One last question. Do you think there's a risk of triggering a paradoxical response?
Paradoxical response, you mean causing more pain?
Yeah.
So we haven't seen that, right? And one of the things I didn't get into, but I do have some early data, is that my focus has always been, okay, this is a nitric oxide donor, right? But it turns out that in the pain literature, arginine is actually a precursor for this other metabolite, chiotorphin, which is L-tyrosine, L-arginine, and it is an endogenous analgesic dipeptide. And there, so again, you have to go out of your field to find this stuff, right? There's a randomized placebo-controlled trial where they're giving it to patients who had complex regional pain syndrome, and it's acting like a pain medication. And so within 30 minutes, you saw a significant improvement in pain compared to placebo, and that lasted for 8 to 12 hours in some patients. So of course that's really intriguing because that has nothing to do with nitric oxide, but it may be functioning also as an endogenous opioid. They were able to block the pain response with IV naloxone. So we did do some early studies looking at this kind of torphin in my pharmacokinetics studies, and arginine does in fact increase this level. Now, whether it gets into, crosses the blood-brain barrier, there are all kinds of questions that I'm hoping that my colleagues with the four-legged sickle cell mice can answer. But I think that arginine is working through a number of different paths. I'm not worried about it causing a paradoxical. I think if you get better with arginine though, and then you stop it and you go home, I am concerned that some may actually have their rebound pain, and that's something that we're looking at in that safety, evaluation in our clinical trials.
Well, Claudia, I mean, we could go on. There's so many more questions in the chat, but I want to let people go on with their day. And I really, really, really appreciate, we'll get all these other questions summarized and bring it back out to the group after Dr. Morris can have some time to answer them. But in the interim, I just want to wish all of you a wonderful day and take care. And thank you so much for being here. I really appreciate all of your time, and be well.
Thank you, everybody.